So before I turn things over to our presenter, I just want to review a few things about the technology we're using today. Since we have so many of you on the line, everyone is and will remain on mute throughout the presentation. We do have time set aside to take your questions at the end, and we welcome you to submit them via the question pane on your GoToWebinar control panel, which you see pulled out on this slide. You can type away, and I will read your question to our presenter to answer. Please also feel free to send me a message via the questions pane if you have technical issues, and I'll do my best to assist you. Please note that we will send all webinar participants a link to the recording, slides, and additional materials after the webinar. The Institute is a public-private partnership launched in 2012 with the support of the Oregon Health Authority and managed by QCorp. Together with the experts we partner with, our goal is to get primary care practices connected to a broad array of technical assistance as they work towards the patient-centered primary care home or medical home model of care. We encourage you to visit our website, pcpci.org, to access resources, including recordings of previous webinars. Like I mentioned, the Institute aims to help primary care practices achieve recognition as a primary care home through the State of Oregon's Patient-Centered Primary Care Home, or PCPCH program. The model consists of a set of standards organized under 6 core attributes, which you see here. You can visit the PCPCH program website at primarycarehome.oregon.gov to learn more. Now I would like to turn things over to our presenter. Ron Jackson, MSW, LICSW, is an affiliate professor at the University of Washington School of Social Work, where he teaches a course about addiction and counseling skills used in the treatment of addiction. He recently retired as the Executive Director of Evergreen Treatment Services, a private nonprofit organization in Seattle, Washington, that provides outpatient opioid treatment to over 1,800 patients in clinics in Washington and provides street-based case management services for homeless addicts through the REACH program in Seattle. He served for 10 years as a co-principal investigator for the Washington node of National Institute of Drug Abuse's Clinical Trials Network. Mr. Jackson has worked in the field of addiction treatment since 1972. Here you go, Ron.
Thanks very much. Good morning, everybody, and thanks very much for attending this webinar. First, a little bit of logistics. I'm happy to declare that I don't have any conflicts of interest here. I have no financial stake in anything that I'm going to be talking about this morning. What we're going to talk about today is medication-assisted treatment, and I'm going to review the various FDA-approved medications. I might say a few words about some of the medications for the treatment of alcohol use disorders that are used off-label. And I'm going to talk about how those medications act as a platform of neurochemical stability to help people who are moving into recovery acquire the behavioral skills and maybe changes in their environment in order to get into a more stable recovery. So we'll talk about each of these medications, and I'm going to start talking about sort of the theoretical constructs that are behind the use of these medications. I'm going to pause after I'm done with the medications for the treatment of alcohol use disorders to see if there are any questions then, and then we'll move along and talk about medications for opioid use disorders. I would imagine that most of you know about the Diagnostic and Statistical Manual in the 5th edition, and these are the 11 criteria that are used to make a diagnosis. And one of the big changes between DSM-4 and DSM-5 is there's no longer an abuse category. It recognizes that addictive disorders exist along a spectrum from mild to moderate, and what determines the person's severity of their substance use disorder is the number of symptoms that are observed and endorsed. The other big change between the previous iterations of the Diagnostic and Statistical Manual and DSM-5 is you'll see noted by that asterisk next to tolerance and withdrawal that there are many medications, including those that are psychoactive. If they're taken on a regular basis, the body will develop tolerance to them, and if they are abruptly discontinued, the body will go into withdrawal. If that tolerance and that withdrawal is as the result of a medication taken as prescribed by a physician or other medical professional and under their medical supervision, that tolerance and withdrawal doesn't count. So that means that the tolerance to, for example, buprenorphine that people will acquire as a result of taking it for their opioid use disorder, and the withdrawal that they might feel if the physician discontinued that, or they decided to discontinue it abruptly, would not count toward the diagnosis of a substance use disorder under DSM-5. So I want to be clear that there is a big difference between physical dependence and addictive disorder. And I use the term addictive disorder and substance use disorder kind of interchangeably. There was a considerable amount of discussion between members of the panel that wrote DSM-5 about exactly what to call this syndrome. So physical dependence is this relationship between the body and a substance, and that occurs as a result of the ritual taking of the drug or usual taking of the drug. Addictive disorder is not about physical dependence. It's about an emotional relationship with that particular substance. And so a person can have a substance use disorder with or without physical dependence, because it's not about physical dependence. I suspect that many of you know that addiction is a complex disorder, and sometimes in our culture we like to simplify things that are very complex. It's not just a function of the drug that a person takes. It's not just a function of their genetic background and the environment into which they were born and in which they currently live, but it's also how that drug it changes the brain over time. Many of you have heard of the definition of addiction as a brain disease, and that's certainly true. So one of my favorite articles about addiction was written by Dr. Tom McClellan and his colleagues, and it was published in the Journal of the American Medical Association back in early 2000. And the purpose of this article was to change the conversation from drug addiction as an acute disorder to drug addiction as a chronic medical illness. Most people, those who struggle with addiction particularly, would prefer to think of addiction as an acute disorder where you go to rehab and you get fixed, or you take a medication for a short period of time and that resets your brain. It's certainly not that. All of the evidence that has accumulated so far illustrates that addiction models like other chronic medical diseases. By that I mean it has a genetic component. Addiction runs in families just like mental health disorders run in families, as do diabetes and hypertension. And so there's kind of a quick recitation of the heritability of these things. But much like other chronic medical disorders, you can also behave yourself into that. Think, for example, about adult onset diabetes, where the insensitivity to your body's own insulin is a result of your behavior, what you eat, what you don't eat, and so forth and so on. It's also very clear that even if you behave yourself into chronic medical disorders, you may well need a medication for an intermediate or ongoing period of time in order to take care of the changes that have occurred as a result of those behaviors. So it's very clear from neuroimaging studies that the brains of addicts are different than the brains of normal people, and probably those brains are different from what the person's brain looked like before they began their emotional relationship and use of a particular substance. We know, for example, that the drugs of addiction hijack the brain's reward pathways. That's in the limbic system of the brain, the ventral tegmental area and the nucleus accumbens that are rich in dopamine. But additionally, they also downregulate, the course of addiction downregulates the prefrontal cortex, which is the site of impulse control. So a person who has addiction not only is triggered by the drug, the site of the drug and so forth and so on, but also has an impaired braking system to resist that strong impulse. And the medications that we're going to talk about here this morning have no effect on restoring prefrontal cortex activity or impulse control strength. The only empirically validated intervention that works to restore prefrontal cortex activity is cognitive behavioral therapy. But the medications that we're going to talk about can blunt withdrawal, blunt craving, and perform a platform of neurochemical stability so that individuals can begin to apply CBT therapy and change their environment in order to regain that impulse control that's so necessary in recovery. So it's important to keep in mind that the medications that we're going to talk about are not curative. In the same way that insulin is not curative of diabetes, or albuterol is not curative of asthma, these are management tools. And so what we're talking about are medications that are used to help people who are in recovery manage their addiction. And the goal of treatment is to make sure that we can find the right tool for them and then teach them how to use those tools. So this is a sort of a graphic way to think about addiction. There are brain changes and dependence that occur in the presence of addiction, and addiction is also yields and sometimes is contributed to psychological and social problems. So the medications that we give help modify or mollify some of the brain changes, block the craving, block some of the withdrawal syndromes that allow people to then get counseling and social supports to deal with the psychological and social problems that either arose in the context of their addiction or were there that helped trigger that addiction. So here are the medications that are available. For opiates or opioids, I'll use the term interchangeably, there are 3 medications, and we'll talk about those here in a little bit. And for alcohol, there are also 3 FDA-approved medications. You'll notice that one of the medications works for both alcohol and opioids, but there are different considerations in the application of naltrexone depending upon whether you're using it to treat someone who has an alcohol use disorder or someone who has an opioid use disorder, and I'll be specific about that. There are some off-label medications that are used to treat alcohol use disorders, and they are baclofen, topiramate, and valproic acid, which you may know by its trade name Depakote. So they are not FDA approved, but there are, if you wanted to go to PubMed and take a look at a search, you could see anecdotal reports about the utility of those 3 medications as well. Here is an evidence base that kind of talks about the depth of empirical support for these various medications. Cochrane review, some of you may be familiar with this, is a process of meta-analyses of various kinds of medications, or for that matter, behavior therapies. You can find out more about it by simply Googling Cochrane review, and you'll see there. But one of the things that I want to point out is the number of scientific papers in PubMed to support the use of methadone, which is often seen as the most controversial of any of these medication approaches. More about that in just a moment. So let's move along and talk about the other substances. For cocaine and other psychostimulants, such as methamphetamine, there really aren't any FDA medications that are available. There are some vaccines that are under trial. Nicotine has a number of medications that are available, some over the counter, some by prescription, and there's some vaccine. I probably won't have enough time to talk about nicotine, medication-assisted treatment of nicotine dependence this afternoon. And for marijuana, there are no medications at this particular time. Okay, so let's focus on alcohol addiction to begin with here. Here are the 3 ways that medications are used to treat alcohol addiction or alcohol use disorders. The oldest is the last bullet there, which is basically punishing alcohol consumption by generating a dysphoric or unpleasant set of feelings when a person drinks. There is also a medication that is used to to block or reduce the euphoria associated with alcohol through the endorphin channel. And then last but not least, there's a medication that helps people deal with or reduce some of the prolonged or post-acute withdrawal that happens from alcohol use disorders. So let's go, I'm going to go through these in kind of the order of their history. The oldest one is a medication called disulfiram. That's the generic name. Many of you know it by its trade name of Antabuse. It's been around for a very long time, over 60 years now, and it is available in almost every formulary and so forth and so on. It's not a drug of abuse. I can't imagine that it has any street value whatsoever, and it works by changing the way that alcohol is metabolized in the body, leading the person who's on disulfiram, who drinks alcohol, into a very unpleasant condition. Here's the kind of cost of it. It's actually gone up over time. It's covered by insurance, Medicare, Medicaid, et cetera, et cetera. It's a once-a-day medication, but it has to be taken on a regular basis. If a person stops taking disulfiram after some days, they won't have the antabuse reaction here in a little bit. A person has to stop drinking for at least 12 hours before that, and one of the contraindications, one of the individuals with whom you can't use disulfiram is someone who has some degree of liver problems. You have to do a liver function test with the individuals to see what their liver values are, and if they are out of range, and that's all on the package insert, then you really can't use antabuse because it has its principal effect in the liver. Here's how disulfiram works. Here are the 3 stages of alcohol metabolism. A person consumes alcohol, that's acted on by an enzyme called alcohol dehydrogenase that actually yields a more toxic substance in the person's bloodstream. That toxic substance is called acetaldehyde. That acetaldehyde normally is rapidly removed by the use of another enzyme, acetaldehyde dehydrogenase, which yields, which makes the next pass metabolite acetate, and then finally it moves on to water and CO2. So disulfiram blocks the enzyme acetaldehyde dehydrogenase, which means that acetaldehyde circulates in the bloodstream of that individual for a longer period of time, and that's what generates the symptoms that I'm going to show you right now. So here are the various kinds of symptoms that a person gets. These can be very, very unpleasant, and so one of the general notions is if you have a patient and you put them on disulfiram and they continue to drink on their disulfiram, it means that it's time to switch a plan. Don't just think, well, I'm going to just up the dose and up the dose. That's probably not the best way to go about it. So that's what this looks like. So the person who is on disulfiram needs to be warned. They need to be told you should stay away from alcohol-based hand sanitizers. You should stay away from alcohol-based mouthwashes and the like, because some people are very sensitive, and contact with even a small amount of alcohol can lead to the disulfiram alcohol reaction in individuals. So that's one of the warnings that you need to give patients. You can't give it to somebody who's actively drinking. They have to stop for at least 12 hours, and so there you have it. I'm going to move along and talk about acamprosate. Acamprosate is probably the newest medication that's been approved by the FDA for the treatment of alcohol use disorders, and it's marketed by the trade name Camprol. There's no street value. It's not a drug of misuse or anything like that. and it acts to sort of help restabilize the brain's neurochemical balance. And I'll show you what I mean here in just a second. Here's the cost. You can start somebody on it while they're still actively drinking. One of the considerations is that this medication has to be taken 3 times a day. So it assumes that the person that you're prescribing it to is going to be compliant with that regimen of dosing. And unfortunately, not everybody that has alcohol use disorders are necessarily going to be that compliant with taking the medication. So here's kind of the whole notion about how acamprosate works. When our brains, when they're in a normal state, have kind of a balance between inhibition and excitation. So alcohol, many of you know, is what's called a GABA agonist. GABA is a neurotransmitter it's an inhibitory neurotransmitter. And so that's what leads to the sedation, the relief of anxiety. It's because alcohol binds to GABA-specific receptor sites inside the brain. Through the process of homeostasis, the brain tries to rebalance that by generating more glutamate. Glutamate is an excitatory neurotransmitter, and so the brain, in the presence of alcohol, starts manufacturing more glutamate to balance that sensation out. When a person stops drinking, now I'm now down to this particular slide right here, when a person stops drinking, that leads to an imbalance of glutamate. That's the excitatory, and that helps you understand the anxiety, the jitteriness, etc., that the person who is in acute alcohol withdrawal feels. And so it takes quite a while for the brain to rebalance itself. And the post-acute withdrawal is often referred to as the protracted withdrawal syndrome. And so there are sleep and mood disturbances. By that I mean typically anhedonic mood and problems of getting to sleep or staying asleep or even getting quality sleep. The purpose of the role of acamprosate then is to try to help balance that glutamate system more rapidly. So that's how acamprosate works. And glutamate is not only an excitatory neurotransmitter, but it's also, we think, the neurotransmitter that's closely associated with physiologic craving. Physiologic craving is not the only kind of craving. There's also that conditioned response type of craving where a person who is in recovery from alcohol sees a glass of alcohol, hears people drinking, et cetera, et cetera. Those are kind of triggers which are different than the physiologic phenomenon of that's associated with GABA. Okay. Now I want to move along and talk about the third medication that's used to treat alcohol dependence, which is naltrexone. Some of you may know the term naloxone or Narcan. That is a short-acting opioid antagonist. The sole purpose, the sole use is to treat opioid overdoses. Naltrexone is the long-acting cousin of naloxone. And it was first developed, and I'll say more about this in a little bit, it was first developed as a treatment for opioid use disorders. And it's an oral medication in this format, a formulation that I'm talking about. And the reason that it became used for the treatment of alcohol use disorders was that as many people who, not many, but some people who have opioid use disorder also have a concurrent alcohol use disorder. And so those individuals, when they were put on naltrexone for the treatment of their opioid use disorders, began to notice that alcohol was less rewarding to them. And so when they drank less or they drank less often. It really changed the reinforcing properties of alcohol for those individuals. So the manufacturers applied to the FDA for the indication of the use of naltrexone for the treatment of alcohol use disorders. And the injectable formulation that I'll describe here in a minute was first approved by the FDA for the treatment of alcohol use disorders, and then later approved for opioid use disorders. So the good news about naltrexone is that you can give it to somebody who is actively drinking. And there's not the same concern about liver health, although that's not inconsiderable. You can use it with people that have a more impaired liver than someone who you would rule out for using disulfiram. This is an oral medication, and so the downside of the oral medication is that it has to be taken daily. In this oral formulation, it's on the formulary in many states, and I believe it's true in the state of Oregon. But you have to take it daily. Dr. McClellan, who's done a considerable amount of research with naltrexone, says it's the best medication that nobody will take. And so when we talk about compliance, that's the reason that the injectable extended release formulation was developed. So the difference, I talked about this earlier, the difference between using naltrexone for people that have alcohol use disorders is that A, you can use it while the person is actively drinking. For opioid use disorders that I'll describe here in a little bit, the person has to abstain for 7 to 10 days. They basically have to get all of the opioids off of their the mu-opioid receptors in order to be able to take this, because this medication strongly binds to mu-opioid receptors. So if somebody has opioids on their receptor sites and ingests naltrexone, they're going to go into precipitated withdrawal, and that will be a very unpleasant experience. So naltrexone is an opioid receptor antagonist. My best explanation to patients about this is think of the opioid receptor sites inside the brain as kind of keyholes into which morphine or heroin or methadone fit. And think of naltrexone as like a wad of gum. You can put that wad of gum into the keyhole. It won't open the door. It won't activate that. In this case, it won't activate that nerve cell, but it also won't let that nerve cell be occupied by opioids. It turns out that there is a subtype of alcoholic whose ingestion of alcohol generates an endorphin reward for that particular individual. So in addition to getting the GABA effects of the relief of anxiety and so forth, they also get the euphoria that's associated with that. And so if you block that reward mechanism, those people find alcohol less appealing. There was an article in The Atlantic last month that describes the reaction of some individuals who have been put on oral naltrexone and how it changes the reward properties of alcohol for those individuals. All right. Moving along, let's talk about Vivitrol. This is the extended release injectable suspension. This was developed, most of the research in this has been done in Russia, and both for opioid use disorders as well as alcohol use disorders. This tries to get past the issue of compliance because it's a once-a-month injection, and it lasts for the entire month. So once a person has been injected with this, it resides there and they can't override it. It's not inexpensive, but when you compare the price of this medication to the price of an emergency room visit for somebody whose alcohol use disorder is driving them into the emergency room on a frequent basis, you can see that there is a particular cost saving. So with extended release naltrexone, there are a couple of considerations. First of all, the person needs to either wear a MedAlert bracelet or something, but cause some sort of notice to to an attending physician that they're on this medication, because if they need anesthesia opioid analgesia for a surgery or something like that, the anesthesiologist, the treating physician, is going to have to take into consideration the fact that they've got naltrexone on board. The other caution is that there is some evidence of increased suicidality in individuals, so it's strongly recommended that the prescriber check in with this person. When we've been involved in naltrexone research projects, and we're in one right now, we screen for suicidality to begin with, and if the person has a long history of suicidality, we tend to exclude them from using this particular medication. But practitioners would need to make their own judgments about that. But that's one of the cautions, and so we're checking in with our patients who are on naltrexone pretty regularly to say, how are you feeling, things okay, and the like. So again, with alcohol, you can inject somebody with Vivitrol before they've even stopped drinking. And our patients that have been on it say it really does change the value of alcohol to them. It's much less rewarding. Okay, I'm going to pause here and see if there are any questions about the alcohol medications.
We haven't had any come into the questions box, but I will just remind all of our attendees, if you do have any questions, you can submit them through the questions box, and I will read them to our presenter to answer. So you can go ahead, I think, and move into opioids, and we'll do questions at the end.
Sounds great. So we're going to move along and talk about opioid use disorders and the medications. So there are basically three ways that opioid use disorders are treated by medications. There is an agonist medication, and many of you know that an agonist, we'll go back to that lock and key analogy that I used with naltrexone. An agonist is like, if you think of a mu-opioid receptor inside the brain as the keyhole, an agonist is like a skeleton key. It fits nicely into that mu-opioid receptor and activates it fully. And so methadone, heroin, morphine, hydrocodone are thought of as mu-opioid agonists. They fully activate that receptor site. There are partial agonists, and partial agonists are like a key that fits in the lock but doesn't really open the door all the way, but it also doesn't let a real key get in there, a real agonist get in there. And so buprenorphine is what's referred to as a partial agonist. It occupies mu-opioid receptors fully, doesn't let agonists get on there, and in fact even kicks, if there are agonists on there, it kicks those off. So that's buprenorphine. And then there are antagonists. I've already explained that those are blockers of the opioid effect. So let me kind of show you this graphically here. On the x-axis is the dose, and on the y-axis is the opioid effect. And so when you take a full agonist, the more you take, the more of an opioid effect you get. And even if a person has tolerance to a full agonist, let's say in the case of methadone, they can still overdose and die by taking a substantial amount more than their tolerant dose. So the safety profile is different for buprenorphine. I'll put that one up next. Buprenorphine is a partial agonist. And there's a point at which a dose of buprenorphine doesn't get any more opioid effect. It's very, very difficult to overdose on buprenorphine. In fact, most of the accidental drug deaths involving buprenorphine have also involved another CNS depressant, typically a benzodiazepine. And so it's safer in that way, this so-called ceiling effect. You can't just continue to press the dose and get more and more opioid effect. And then last but not least, the antagonist, which is either naloxone or naltrexone, it doesn't even have any opioid effect. So those are the three strategies. Let's start with the agonists here. It's surprising to me. I've been in this field now for 43 years, and it's surprising to me the level of resistance to to medication-assisted treatment for opioid use disorders. And this is despite basically an avalanche of research that substantiates the effectiveness of these medications. So here's how, this is about methadone. So it binds to the receptor sites. The reason that that we use it as compared to morphine is that it's long-acting. So you only have to take it once a day, and it's orally effective. Some of you may know that there have been some heroin maintenance clinics established in Europe, and now there's one in Vancouver, British Columbia. And the problem with doing heroin maintenance is that it either has to be smoked or injected, and it's short-acting. If you want to give this medication to kind of stabilize and give people a platform of neurochemical stability, you'd like for it to last for a full day so that they can go on about their business, take care of their kids, go to work, do job training, whatever the case may be. So here are a quick recitation of the outcome data. In fact, the Nixon administration was the executive administration that first put forth methadone as a treatment modality, and they did it because there was a significant body of evidence at that time that putting heroin addicts on methadone reduced their criminal activity substantially. And as the years have gone by, we also see things like a reduction of drug use and engagement in recovery activities and so forth and so on. It also helps stabilize a person's stress response, and most importantly, from a public health standpoint, is the reduction of blood-borne infections, specifically HIV and hepatitis C. We know from all manner of addiction treatment research that retention in treatment is a very important element in predicting the probability of successful outcome in treatment, because it's a chronic disorder. If people, it takes a while. You can't walk into treatment with a 5, 10, 15, 20-year addiction history and expect to overcome all of the issues that you have to deal with in 30 days or 90 days. And so this medication, as I said, gives people a platform of neurochemical support that allows them to participate fully in counseling, behavior change, and the like. I want to talk a little bit about pregnancy and methadone. I'll also talk about pregnancy and buprenorphine here in a little bit. The gold standard for the treatment of a pregnant opioid-addicted woman is to put her on methadone because it's a more stable fetal environment. And if you think of a woman who is out on the street using heroin and is pregnant, there's going to be a lot of ups and downs in serum level of opioids as she finds drugs or doesn't find drugs, and that can contribute to something that we call the intrauterine abstinence syndrome. And so you want to stabilize that fetal environment by putting her on methadone. People who are opioid treatment providers know that it's a very good idea to split the dose so that the woman takes half of her dose in the morning and half in the afternoon, particularly as she moves into her third trimester. The regulations for treatment of pregnant opioid addicts require a lot of attention to prenatal care. There is an incidence of neonatal abstinence syndrome. This is where the baby goes into opioid withdrawal. By the way, they are not born addicted. Addicted is a behavioral term. They are born physically dependent, and so some of those infants will need medication care in a NICU, a neonatal intensive care unit, and it's not, the probability of that is somewhere in the 60 to 70% range. There have been variations in studies about how frequently it occurs. Most people incorrectly think that it's associated with mothers Methadone dose, in fact, it's not about her methadone dose. One study seemed to associate the probability of neonatal abstinence syndrome with mom being a smoker. A pack a day smoker or more during her pregnancy increased the baby's risk for having neonatal abstinence syndrome. The other thing that I want to point out is that breastfeeding is actually endorsed by the American Academy of Pediatrics. Breastfeeding for newly delivered women on methadone, it's beneficial to both the baby and mom for that breastfeeding to occur unless it's otherwise medically contraindicated. So the question always comes, how long do people need to be on? And my short answer to that, as long as they need to be, as long as it takes. If you think of it like this, there are three kinds of opioid addicts. There are people who, because of their genetic history, because of their years of use, relatively slight years of use, etc., may not need any medication at all, other than a slight amount of medication perhaps to help them over the miseries of opioid withdrawal. There's another group, and this is not a 1/3, 1/3, 1/3 ratio. There's another group who, again, because of genetics and because of years of use, have some damage to their, some abnormalities to their endogenous opioid system and need medication for an intermediate period of time, 6 months to 2 years, let's say, while they go about the business of changing their behavior, changing their environment. And once they change those risk factors, they eliminate those risk factors, they could be tapered off of the medication and continue on in a medication-free recovery. And there's a third group who, despite all of the behavior change and environmental change, have permanently dysregulated their endorphin system and are going to need that medication indefinitely. It's the same kind of thing that you see with hypertension. There are some people that need antihypertensive medications for a short period of time and others need them indefinitely. The problem that we have from a clinical perspective is there's no research evidence that help us identify which group that patient fits in. We can't tell this person, you only need it for a little bit, you need it for a good bit, you need it for the rest of your life. That's the clinical dilemma. There's really no way to tell. Everybody wishes that there was. So under DSM-5, they have physical dependence, but they are taking that medication under the supervision of medical professionals, so they would not meet a DSM-5 diagnosis of opioid use disorder if they were absent those other 9 symptoms that I showed you. I'm moving along and talking about buprenorphine, and there are 2 formulations of buprenorphine. I'll say more about that in just a little bit. Here are the trade names that you're probably used to hearing. There's Suboxone and Subutex. Those are the trade names from the product manufactured by Reckitt Benckiser. They have a new corporate name, and I can't remember it for the life of me. And then there's a new medication called Subzolve, and that's always a combination of buprenorphine and naloxone. The reason for the naloxone being incorporated in this sublingual tablet or the sublingual film was to minimize the probability of diversion. If you put Suboxone under your tongue or Subzolve under your tongue, you don't absorb any of the naloxone. And remember that naloxone is Narcan. You don't get the antagonist effect. But if you were to take that tablet, crush it up, and inject it, you would get a whopping dose of naloxone. And if you had opiates on board in your brain, you wouldn't like that. You'd have precipitated withdrawal. So this is a sublingual tablet, and a person has to be in pretty moderate to severe withdrawal in order to be able to start taking the medication. I'll say more about that in a little bit. The enabling federal legislation is something called Data 2000, and it authorizes physicians and physicians only, not nurse practitioners or PAs, even though buprenorphine is a Schedule III drug, and in many states nurse practitioners and PAs have Schedule III prescriptive authority. The federal law stipulates that only physicians, MDs and DOs, can do this. They have to go through training. It's an 8-hour training. It can be done online. There's an amendment to the DEA license. It's an X that's put on the end. In the first year of practice, you can have up to 30 patients, and then you can petition the Center for Substance Abuse Treatment to expand your capacity to 100 patients after that first year. The differences between methadone treatment and buprenorphine treatment is that methadone treatment for opioid addiction has to take place within the confines of a clinic-based program, and there are all kinds of rules about urinalysis, rules about treatment plans and counseling sessions and the like. Buprenorphine takes place in an office-based practice, and there are no federal or state rules about that. And so there's a wide variability in practice in office-based buprenorphine. Some physicians require urine testing and will make their next prescription refill conditioned on that. Others don't. Some require attendance at fellowship support groups. Some don't, and so forth and so on. In the state of Oregon, I don't have the slide in this presentation, but there aren't many buprenorphine authorized physicians east of the Cascades in the state of Oregon. I could go into a long recitation about why that is. This is somewhat self-explanatory. This is a study called the Mother Study. It was a multi-site trial. Patients were randomized into buprenorphine or methadone. It was double-dummy, double-blind. They were getting observed dosing, and they used plain buprenorphine. And the reason for that, and the recommendation is, if you're going to treat a pregnant opioid addict with buprenorphine, it needs to be the mono form because there haven't been any fetal safety studies done with naloxone, which would be present in the Suboxone or the Subzol form. And what the study found in a nutshell was that babies who were born to mothers who were on buprenorphine had less neonatal abstinence syndrome symptoms, and they were in a hospital for a shorter period of time. There weren't any differences in outcomes for mother, and there weren't any differences in the frequency of neonatal abstinence syndrome. It was just the intensity of those symptoms. The prescription opioid treatment study was done, multi-site trial. The idea here is that perhaps people who were prescription opioid addicts as compared to heroin addicts would do better on buprenorphine than methadone. And this was an adaptive study. I'm not going to go into all of it in detail. Suffice it to say that whether this was buprenorphine was used for detoxification over a 21-day period or for intermediate term treatment, meaning 3 to 4 months, the medication only worked when people took it. And once they stopped taking it, they reverted to opioid use. And I could go into more detail, but I'm not, in the interest of time, I'm not going to. Opioid antagonists can be used for the treatment of opioid addiction. There is a growing interest in the use of antagonists in the criminal justice system. You've got an opioid addict who is opioid-free in prison, and prior to release, you might, with their permission and participation, put them on an opioid antagonist, so once they get out of jail, if they were to relapse to opioid use, they wouldn't overdose and die. One of the big differences between relapse to opioid use and relapse to alcohol use is that relapse to alcohol use is rarely fatal from an overdose standpoint. It may be fatal because of traffic accidents or whatever, but with opioids, one of the high risk factors for opioid overdose is detoxification. People's tolerance goes down, and they use and then die. So the idea with Vivitrol is that the person has to be drug opioid free for about 7 to 10 days, and that window is a window of vulnerability. Getting somebody who's opioid dependent off of opioids for a long enough period of time to be able to inject them with naltrexone is one of the issues in using that medication. So I'm going to stop here. I know that opioid overdose is an issue in your state as it is in our state and virtually every state in the union. I just wanted to put this slide in here that helps you understand that you can get CSAT's overdose prevention kit at a website that you'll see in the resource slide in a little bit. So I'm going to stop here. We've got about 10 minutes left to take questions.
So we do have one question so far, and it's a two-part question. So the question is, are there side effects of naltrexone, and how long before it's effective? I think this is referring to its alcohol use.
Yeah, there aren't any side effects. If it's the injectable formulation, sometimes people have injection wounds. They get a little bit of soreness there. We've had one case of an infection, and we're not quite sure how that infection occurred, but there aren't any. There's no sort of intoxication effects of naltrexone. There have been concerns that perhaps it sort of contributes to anhedonia, but the jury's sort of out on that. But it's not psychoactive from that perspective, where you get impaired. And how long will it take? Well, if you're taking it orally, it's going to take a half an hour to get into your bloodstream and get to your brain. If it's injecting, it's going to probably end up in your brain in about 5 to 10 minutes, maybe a little bit longer.
We just got another question. Is there an adequate supply of accredited treatment centers in the state, and if no, why?
The short answer is no. In the state of Oregon, the opioid treatment programs that exist are largely in the main cities of Portland and Eugene, and there's one in Medford, and there's one over in Bend now. And the reason that they don't exist widely is, first of all, there's a lot of stigma associated with opioid treatment programs. People don't want them in their neighborhood, don't want them in their city, and so they're reluctant to agree to the siting of it. My agency opened a clinic down in Grays Harbor County on the southwest coast of Washington, and actually we were welcomed with open arms there because community leaders and community members understood that they had a huge problem with both heroin and prescription opioid use, and they saw us as being helpful in dealing with that particular issue. I've actually been to your state several times to try to talk to community groups about what it might take to start out opioid treatment programs. And as it relates to buprenorphine prescribers, there are a lot of physicians who just are kind of shy about getting into this business. They worry that if they're the only physician in their locale to be a buprenorphine prescriber, that they'll be inundated with addicts, and they don't have the staffing to deal with that. They worry a good bit about that. They don't want their primary care practice necessarily just overrun with opioid addicts who might be very desperate to get this form of treatment. There was a study done in our state that was one of the principal reasons. Also, the idea that they didn't feel like they had enough resources in their community. And by that I mean counseling services that were agreeable to taking people who were on a medication-assisted form of treatment. So it's a complex social issue, and I'm a big advocate for it being more widely available. It's hard to ask people to drive 2 hours one way to get to a methadone clinic, or an hour one way to get to a buprenorphine prescribing physician.
Well, thank you. So those are the only questions that we have gotten so far.
So let me go along then, and I'm not going to talk about nicotine medications. There are resistances that occur to medications, and sometimes it's the influence of others. People who are on medication-assisted treatment, particularly for opioid use disorders, are not always welcomed with open arms in fellowship support groups. Often they have to be kind of silent about the fact that they're on buprenorphine or they're on methadone in order not to be actually harassed or challenged about that. even though the principles of AA are supportive of people taking medication under the care of a physician. But there's also this notion that somehow a medication-assisted recovery is inferior to a quote-unquote abstinence-based recovery. There was an opioid overdose conference recently in Seattle, and people came from all around the state, and it was law enforcement and criminal justice and medical professionals and the like. And one of the speakers there was a woman who had lost her 19-year-old daughter to an opioid overdose. And I happen to know this person from past interactions. And I went and I talked to her and I said, was your daughter ever offered buprenorphine for her opioid use disorder? And she says, well, I think she was, but she didn't want to do it. She wanted to do it, quote unquote, on her own. And honestly, I couldn't help but believe that her daughter would still be alive today had she been on that medication. So that's that. I'm going to move along now and talk about, here are the resources. These are all the places that you can find out about it. The buprenorphine website is there. You can see that there is a SAMHSA publication about the clinical use of extended-release injectable naltrexone. That's Vivitrol. So those providers out there, those programs that are thinking about using it, you have a guide to do that, and there's the link to that particular guide. The Center for Substance Abuse Treatment, which is part of the Substance Abuse Mental Health Services Administration, publishes best practice guidelines. They are referred to as treatment improvement protocols, or TIPs. There are TIPs that, tip 40 is all about buprenorphine, and tip 43 is all about treatment of opioid addiction. You can get that at the SAMHSA store. If you just Google SAMHSA and then look under the tab that says publications, you can put these, you can put tip 40 or tip 43 in the search engine and you'll find it. It's fully downloadable, and there you go. So I'm kind of at the end of my talk. See if there are any more questions, and we can talk about the survey.
So there are not any more questions. So I will just note that there will be a survey after the webinar once we close it out, and we would encourage all of you to please complete that survey. And we thank you all for attending today. It was a great session, and again, the webinar recording and slides will be sent to all attendees, so you will have all of the information.
Yeah, I want to thank everybody for coming in today and attending the webinar, and I appreciate your efforts and support on behalf of people who struggle with substance use disorders. Thank you very much.
All right, thank you, everybody.